Ganesh is going to talk about our experience here, Cheshire and Merseyside Rehabilitation Network, over the last 2 years. Thank you very much, Ganesh.
Thank you. Good morning. One who was not here in the previous talk, or one who had a short-term memory. I just want to recap a couple of things my colleagues, Professor Lynn Turner-Stoke mentioned. There are multiple problems after a major trauma, and there is a trial-based or the practice-based evidence, the strong evidence to say that early rehabilitation improves the outcome. Whole pathway should be there, and it should be network approach to have a best outcome for the patients. And there's also Dr. Greenwood has kindly mentioned about the early rehab again, and the seamless rehabilitation and patient-centered multidisciplinary rehabilitation improves patient outcome, and it's clinically effective. So on that background, let's start what we have done. First slide is an acknowledgement to all my team members who kindly standing there and supporting me, and all the clinical and non-clinical team who is actually working on the ground and making it to happen. And so it's not my slides, it is a slide of our hospital and our team who's kindly doing this work together as a team. Sorry. This is the video we will be showing to our patients about what is this rehabilitation network is about.
A traumatic illness.
Sorry, thank you. When the patients come in, majority of the time, what is rehabilitation? What is specialist rehabilitation? What are they going to get if they come into the rehabilitation? Very few or patchy or varied ideas. So we're trying to show this, put it in our website, and trying to show to the patient what they can expect from a specialist rehabilitation when they come as an inpatient or as outpatient, and how long they're going to stay.
Rehabilitation Network. We support people who've experienced a traumatic illness or injury along a pathway of care. We offer a range of services across hospital and community settings which can be accessed at any point during your rehabilitation. Your pathway will be tailored to meet your needs, and whatever happens, you'll have an amazing team of experts on hand 24/7 to work towards getting you home and reaching your potential. Here, we'll explain about how we work and the kind of support you can expect. When meeting someone new, we don't see a patient, we see a person. Rather than just looking at your medical needs, we look at who you are. For instance, who your family and close friends are, and what kind of job you do, your hobbies and passions, and any pet hates. Everything that makes you unique. This way, we have a much better idea of how to rebuild the whole you. Once you're onto the rehabilitation care pathway, there are lots of different possible routes depending on your goals and needs, but the important stages are the same for everybody. First, there's admission and assessment. Then we work with you and your family to set realistic short and long-term goals. We'll start with small ones first and build up to bigger ones. By communicating with you, we can fine-tune them as you go along. At times, it may be frustrating and difficult, but we'll be there to give you the support, encouragement, and motivation you need at every stage. Because we're a network, your treating team is made up of lots of different people with different skills. All of them are specialists in rehabilitation for people who have had a traumatic illness or injury. We work together and are communicating all the time. The Rehabilitation Coordination Team are the first people you will meet, and they'll help guide you along the pathway from start to finish. You may also meet rehabilitation consultants, physiotherapists, occupational therapists, speech and language therapists, dietitians, psychologists, psychiatrists, nurses, vocational rehabilitation therapists, social workers, and all kinds of other health professionals and support staff. But everything we do will be tailored around you and your family's needs and wishes. Regular goal setting meetings help us make sure your rehabilitation programme is on track, so we can help build the best possible future for you as fast as possible. As well as your physical and cognitive well-being, we will help you and your family with difficult emotions too, by offering a safe environment for you to talk about your feelings. Our ultimate aim is to help you be as independent as possible, and everything we do has our 6 values at the heart. Whether you're staying in a rehabilitation unit or being supported at home by our community service, your care will be second to none, and when it's time to say goodbye, we'll leave you in very good hands. We'll get you there and help you build a new life using everything you can do.
So, yeah, it will be in our website, and it will be it's in development at the moment. So in the next half an hour, we'll try to talk about why this rehabilitation network came in place. What has made us to build this network? What was the national and regional drivers which made it to happen? And what's our framework? Who was our framework or partners in doing this or in the network? And how is our performance and activity? Professor Linton-Stoke already touched on that, so I will just look into a little bit more in detail on that. So we established in January 2013. So before that, like anywhere else, like majority part of the country, we were limited provision for rehabilitation, whether it's looking into acute rehabilitation, whether we're looking into major trauma rehabilitation, whether we're looking into whole pathway of rehabilitation. It's all been limited and non-coordinated, if I put in that way. But we thought through, and there are some regional development were happening, major trauma collaboration was coming, critical care network were coming, more and more patients being saved. Those who watch news, you have heard that last few months ago in the Northwest that we are saving 60% more patients through this major trauma collaborative. So critical care again saving more patients. So we knew that more and more patients with this advanced science and more networks are saved. The quality of life is a different question. So we knew, or with all the national guidelines which is coming through, and the BSRM guidelines and the UK ROC guidelines, we know that rehabilitation is an integral part of any other services to survive. So again, BSRM already put forward how the network should structure and what is the staffing level should be, what are the levels are, how to provide an hyperacute rehabilitation, how to provide acute till the community rehabilitation. So our key aims when we are setting up the services were to develop a best clinical outcome for the patient through a coordinated and multidisciplinary approach, and the specialist rehabilitation provision based on the need and not on a diagnosis. So that makes us another unique thing, because we provide even non-head injury as well. So it's not only neuro rehabilitation, we are a specialist rehabilitation service, and we know that it's going to be even further increase and unmet needs are going to come in the future. So our strategy again to look into and provide an excellent patient care through who is being delivered by a high caliber workforce in a cost efficient way. Obviously we need to look into the NHS how it's going. We need to look into the cost efficient way of providing service which is patient focused. So we knew that we can't do it all alone, and we know that we have to work with the partnership around the network to make sure that this happens in a seamless pathway for a patient who unfortunately sustained a brain injury or a trauma or a critical illness. So this is how we recovered both in acute sites and the community. So all these partners, 7 partners working in partnership to develop this model of rehabilitation. So Walton Centre, where you are sitting here, hosts the hyperacute and acute rehabilitation ward, where patients are managed very early following their critical illness or injury. And when the patients are recovered, this is a level 1 hyperacute and level 1 acute. And when it comes to when the patients are getting better and having more active role, then they can move on to the level 2B units, which is based in the St. Helens 20 bedded, or in Royal Liverpool, that is a Broad Green unit, 15 bedded units. And the patients unfortunately making a slow recovery, but they are recovering and needing a long term placement. There is an extended rehabilitation unit, which length of stay up to 1.5 years under Health and Social Care Partnership, which is based in Oakville Gardens. And we also provide looking into the specialist community therapy, who either the patients who can go home straight away or can go home after one step of rehabilitation with some support, that can be gone home early and don't need to stay in as an inpatient for those rehabilitation. So this is the area we cover. So obviously we cover the Merseyside, Wirral and the Cheshire, and the hub has been covered by all the Cheshire and the Merseyside, whereas the spoke bed, the level 2B units or the active rehabilitation units, cover only Merseyside. We also cover population of Isle of Man and North Wales too from time to time. And we have patients here who from North Wales as well. Yeah. So what is our unique selling point? Compared to any other rehabilitation network, we are not a neuro rehab network, we are a specialist rehabilitation network. We got a single point of coordination. So if the, for example, if the clinician sees many patients, I think the categorization, classification is a bit confusing, and it could be confusing even for the rehab consultants at some point. And we need to work. So for the referral, if they're in a cardiology or in a neurology, I can't expect them to refer to the right direction. So we have a single point of contact who don't, if they realize that this patient need a specialist rehabilitation, then they just need to do is pick up a phone and or just 2 pages of referral and refer to the single point of contact. We will do the categorization, we will classify the patient, we will look into the complexity, and we will take them into the right place, whether it's a hyperacute, acute, active rehabilitation or community rehabilitation. Or if we think that this patient doesn't need a specialist rehabilitation, or then we will signpost them to the right place. We will not say that we don't want to, we can't do that. No, we can't do it. However, would you like to consider intermediate rehabilitation? Would you like to consider adult rehabilitation, or some sort of like that? We have a named coordinator in each unit. So we know that communication is the key. In a rehabilitation, the most important thing required is a communication between the patients and the team members. Of course, we always try continuously communicate on throughout, but to enhance that, rehab coordinator becomes an integral part of every unit. We have a vocational rehabilitation in our active rehabilitation, and in the community too. We have a dedicated neuropsychiatry and neuropsychology colleagues, social workers, and we know we cannot do it. Even in spite of all this partnership, we cannot do it still within NHS only. Patients will have an ongoing needs on a long term. So we need to work with the patient charities, support groups, neuro support. Chief Exec was here a minute ago. I'm missing her. So we are working with the third sectors and the patient support groups too. It's all fantastic in theory. But how did we really do in last 18 months? This is now 2 years. Actually, it's more than 2 years now since we started, but it's 18 months figures I got in my hand now to present to you. Who used our service? So like anywhere else, the major patients who are unfortunately going through the severe needing specialist rehabilitation are neurological injury. But one of the things I wanted to point out, 13% of the patients are non-neurological injury. So if we made that as a specialist neuro rehabilitation service, probably these 13% of patients who had a major trauma would not be able to access the rehab pathway. So that's one of the point I wanted to pick on. We are not ageist. We are covered through all group of patients above 16 years throughout, and it's almost equally been covered. Rehab complexity scale, Professor Turner-Stoke already gone through what's the requirement for different levels, and we are taking, so we are not taking patients who are less complex. We are taking complex patients even above and normal than our national requirement. So that's our complexity of the patients. So we are all, what is category A are the high dependent patients needing a specialist rehabilitation. Majority of the patients coming in are specialist rehabilitation as per the specification. Waiting time. One of the things I am very proud to say about the single point of contact has significantly reduced the waiting time. We set ourselves a different target, so that it is a regional, our local target, so that we can keep an eye on that, or make sure that every patient get an early assessment by rehabilitation. Apart from the rehab prescription and within 72 hours after a major trauma. So, if any patient's been referred to a single point of contact, what happens is our coordinator team will go assess the patient and discuss with the consultant. Once the patient been appropriately medically accepted, we have taken within 2 days. 1 in 2 patients have come within 2 days of once accepted the patient. Average length of stay was 3 days, and you have seen that almost 90% or 99% of the patients have taken within that 2 weeks of our own target. 1% who are not gone, we looked into that, why they have not taken as well. That is due to infection reasons or the single sex accommodation. That was the reason why they could not come, otherwise they would have been there as well. Waiting time in a community as well, you have seen that 1 in 5 out of the community rehabilitation is seen within 7 days. And significantly 75% of the patients within a month, which is good for the community rehabilitation service, and so is in outpatient service as well. Just to clarify what is this patients and what is episodes are. Patients are number of patients gone through the pathway, but you have seen the pyramid structure. So, even if the patient coming to hyperacute, that is 1 episode, then they moved on to the acute, that will be 2nd episode. Or if they gone from the hyperacute to the community, that is the 2nd episode. Just to clarify, in that pyramid structure, the patients are usually goes in getting better, and they go from hyperacute to acute, or hyperacute to home, or hyperacute to community. They can have an entry or an exit at any point. So, they might say that patient might come straight away to the community and go home, or patient may come to hyperacute and then downward, or in a very small proportion of the cases, if the patient deteriorate and was in a level 2 units and want to unfortunately deteriorate due to the medical or surgical condition, they can be or rather moved upwards in the pyramid as well. So, how many patients we had? We treated in those 18 months 529 patients, and they had 770 episodes, because they had more than 1 level of tier of rehabilitation required. But 2 out of 3, 67% of the patient needed only 1 level of rehabilitation, and only 1 out of 5 needed 2 levels of rehabilitation. A teeny minority needed more than 3 levels of rehabilitation. I hope I am clear in that what I said. Meeting criteria. We set ourselves, or rather we gone around talking about the rehabilitation, what is rehab about, and what is specialist rehabilitation, and refer us. What we did not want, a single patient missing the opportunity of rehabilitation. Even if we get a wrong referral, that is fine. That is fine, because you do the work. sorry Paul. But we do the screening criteria ourselves, and we wanted more referral to come in. So, yes, of course, we are getting more patients to be referred in than appropriate in a rehab network. I think that is fine. So, about 61% felt that they need a specialist rehab, and they have been taken. The one who is not meeting the criteria, still we are not saying that we are not meeting the criteria, go away. We are saying that if not meet the criteria at this point of time, either we will monitor that, or we will tell you what is the best way forward for this patient's outcome from a rehab point of view. So, these are the numbers which are in a gone through the different units. Community, again, the 75% of the referrals meet the criteria, and the significant have been seen already. This has been set up about since around the same time, but this is it right? And the broad green one has started recently. The outpatient service has been recent. That is why you will see the low numbers. So, where are the patients coming from? Obviously, the hub and spoke whole model is available for the Liverpool patients. So, undoubtedly the majority of the patients who came are from Liverpool CCG, but there are all other nearby Cheshire, Warrington, and the Wirral patients are also been involved. The length of stay, how long patient need to wait before they go out. This is the forecast. We have set ourselves target, probably around 3 months of stay in hyperacute, about 3 months of stay rehabilitation in acute ward, about 3 to 4 months in a level 2, that's active rehabilitation in it, either in St. Helens or Broad Green. That's our target for ourselves in the network. But we surpassed that quite well, and the mean length of stay was 70 days, but in every levels we have done much shorter than our own targets, much shorter than what we expected. Discharges. So where are we successful? One of the successful is where the patient gone. Did they get better? Did they improve the quality of life? So where the patient gone? 4 out of 5 patients gone home. So I think that's great. And these are the patients who had sustained a severe injury or illness. So they may be in one of those patients who came in tracheostomy, who's not able to move around, and who's completely dependent for all the cares. And only 19% who has not gone home. We looked into why they have not gone home. Where did they go home then? Because we know that, as I mentioned earlier, the couple of services unfortunately from the Cheshire side don't commission for the level 2 or the further beyond the rehabilitation. So we had to transfer them to the other specialist rehabilitation. The rest of the, unfortunately, they do have some medical complications. So some have gone to acute hospital with the medical complications. The teeny minorities, a total of 28 patients out of 526, if I remember numbers, they have gone to long-term placement. So 100% of the patient who comes to will have an access of the full MDT team. Did they do well? In the rehab complexity, as Professor Lintonstock always says, rehab complexity reduces. Yes, it is reduced. And FIM-FAM, you already mentioned, it increased in averages increased significantly higher on discharge, which also says that patient got better in simple terms. So goal attainment. Goal attainment, we have seen 75% of the patients have or more have achieved more than 90% of their goals, with 1 in 2 achieving 100% of their goals. Yes, there are maybe some teeny minority are not meeting 90%, which means that we are looking into that. We are processing realistic goals. It happens in a part of our rehabilitation, and so is in the community too. Vocational rehabilitation. One of the proud things to be seen here is we are having a vocational rehabilitation. Another important thing which I forgotten before, in active rehabilitation unit, which is a level 2B, we have piloted 7-day rehabilitation. That is the 7 days or extended hours rehabilitation in level 2 active rehabilitation units. So 607 episodes of vocal rehabilitation. So we all patients who are needing either to go back to work or want to go back to education or even voluntary work, or in some very teeny majority maybe help to self or leave the job, because that's also sometimes can be difficult. So they're all needed to be helpful, and 70 patients have returned to education or paid voluntary work or something related with their work. How do they feel? Patient feel about us. We looked into patient survey, looking into how do they feel that they are involved in and planning in their decision making. Do they think they are involved in their care and responsiveness? Do we treat them in the dignity and privacy? And how do they satisfied, and will they refer or will they recommend us to their friends? Over 90% for everything. They all felt they have been very involved, very they are satisfied with the care and responsiveness, and they've been treated with the dignity and privacy. They're very satisfied or satisfied, and they feel that they'll recommend, which is this is all goes to the team, and probably our rehab coordinator in each ward also enhance this communication. This is not one-off patients. This is the patients we recurrently are hearing again and again. Good things about whether you are in whichever ward, whichever units you are in, they are giving a very good feedback about the way they are treated. In summary, I'm finishing early, early lunch for you. In summary, what do we do in Cheshire and Mersey Rehab Network? We do rehabilitation. We are a regional coordinated service. We are very efficient and effective in our process. We do patients as a holistic approach, not a single point, or not a seeing for a disease, not looking for just a brain injury. We look them as a person as a whole. We achieve all the regional targets which we set ourselves, or the national target which has been set on us, and we based on rehabilitation needs and not a diagnosis. That's the most important thing. Thank you. And this is the numbers which is the contact numbers of the team there. And if anybody has to refer any patient, this is the only number and only email they need to remember. They don't need to think which consultant, which unit, or where the patient needs to be referred. And they'll be referred there, and they will be screened and pointed in the right direction. And I also, before I'm finishing, I wanted to thank Paula for what and doing this fantastic building. That's the person behind this building, actually. I know that you told me not to embarrass you, but I decided to do it myself. Sorry.